Hi, I am Shravani. I am in MPH second semester with epidemiology as my main concentration. My topic today is the effect of metformin and intensive lifestyle intervention on the metabolic syndrome, the diabetes prevention program, a randomized clinical trial. So, what is metabolic syndrome? Metabolic syndrome is a cluster of metabolic disorders. When a patient presents with these conditions together, the chances for future cardiovascular disease is greater than any one factor presenting alone. For example, if you consider high blood pressure, this alone is a serious condition. But when a patient has high blood pressure along with high fasting glucose levels and abdominal obesity, this patient may be diagnosed with metabolic syndrome. There is a greater chance this patient will have cardiovascular problems because of the combination of risk factors. Metabolic syndrome is a serious health condition that affects about 23% of adults and places them at higher risk of cardiovascular disease, diabetes, stroke, and diseases related to fatty buildups in artery walls. The underlying causes of this syndrome include overweight, obesity, physical inactivity, genetic factors, and getting older. This syndrome occurs when a person has three or more of the following measurements: abdominal obesity, triglyceride level of 150 milligrams per deciliter of blood or greater, HDL cholesterol of less than 40 milligrams per deciliter in men or less than 50 mg per deciliter in women, systolic blood pressure of 130 millimeters of mercury or greater, or diastolic blood pressure of 85 millimeters of mercury or greater, fasting glucose of 100 milligrams per deciliter or greater. Although metabolic syndrome is a serious condition, you can reduce your risk significantly by reducing your weight, increasing your physical activity, eating a heart-healthy diet that's rich in whole grains, fruits, vegetables, and fish, and working with your healthcare provider to monitor and manage blood glucose, blood cholesterol, and blood pressure. As we all know that lifestyle interventions, if implemented seriously, will help in preventing many chronic diseases. But today we are going to compare the effect of intensive lifestyle intervention and metformin therapy on the syndrome's incidence and resolution. So metformin is used with a proper diet and exercise program and possibly with other medications to control high blood sugar. It is used in patients with type 2 diabetes. This trial took place in research and community-based centers. There are a total of 3,234 participants who were recruited between June 1996 and May 1999 from a variety of sources, including community screenings, household mailings, on the basis of perceived risk of diabetes. Written informed consent was obtained from all participants before screening, consistent with the Declaration of Helsinki and the guidelines of each center's institutional review board. Participants were randomly assigned to three treatment arms. One is standard lifestyle recommendations plus metformin, 850 milligrams twice per day, standard lifestyle recommendations plus placebo, and the third one is intensive program of lifestyle intervention. Random treatment assignments were stratified according to clinical center and were generated by the coordinating center through computer link-up to the field center at time of randomization. Therefore, assignment was unknown until randomization. Assignments to the lifestyle group were blinded until randomization, whereas assignments to metformin and placebo were double-blinded. The study design and analysis followed the intention to treat principle. Standardized interviewer administered questionnaires were used to obtain self-reported data on personal medical history, medications, and diet. Self-reported race or ethnicity was classified according to the question used in 1990 U.S. Census questionnaire. Overall adiposity was assessed by body mass index. Waist circumference was assessed in the standing position midway between the highest point of the iliac crest and the lowest point of the costal margin in the mid-axillary line. All anthropometric measures reflected the average of two measurements. Blood pressure was measured twice at 30-second intervals by using a standard mercury manometer. The participant was seated in a chair for 5 minutes before the first measurement was taken, and the mean of the two readings was used in the analysis. Coming to the inclusion criteria, as here we are primarily looking for those who are in a pre-diabetic state of hypoglycemia but not essentially diabetic. We are including only those with fasting plasma glucose level of 95 to 125 milligrams per deciliter, and 2-hour plasma glucose level of 140 to 199 milligrams per deciliter. Age of at least 25 years, because below this age, the risk of type 2 diabetes and metabolic syndrome is very low. And body mass index of at least 24 kg per meter square. Exclusion criteria are recent myocardial infarction, symptoms of coronary heart disease, major illness, previous diagnosis of diabetes, use of medications known to impair glucose tolerance, or triglyceride level of at least 6.8 millimole per liter. Participants were followed for an average of 3.2 years. Participants were seen quarterly when blood pressure was assessed. Fasting glucose levels were determined at the 6-month visits, and fasting lipid levels and waist circumference were measured annually. The study design and analysis followed the intention to treat principle. This slide shows the number of participants assigned to 3 arms with number of visits. Here we can see the number decreased by third visit. As the study increasingly eliminated participants with the metabolic syndrome who had developed diabetes or other cardiovascular diseases as they age. The primary outcome is to look for the development of metabolic syndrome. The metabolic syndrome was defined according to criteria from the National Cholesterol Education Program's Adult Treatment Panel 3, having 3 or more of the following conditions: waist circumference greater than 1 or 2 centimeters in men and greater than 88 centimeters in women, serum triglyceride level of at least 1.7 millimole per liter, high density lipoprotein cholesterol level less than 1.03 millimole per liter and less than 1.3 millimole per liter in women, blood pressure of 130 by 85 millimeter mercury or greater, fasting plasma glucose level of 6.2 millimole per liter. The secondary outcome was to look for the lifestyle changes to achieve and maintain a weight reduction of at least 7% of clinical body weight through a healthy, low-calorie, low-fat diet, and to engage in physical activity of moderate intensity, such as brisk walking for at least 150 minutes per week. Nominal p-values and confidence intervals are reported. Logistic regression was used to compare the prevalence of the metabolic syndrome and its components at baseline among demographic variables. The time to the outcome was assessed by using life table methods. Modified product limit curves for the cumulative incidence of the metabolic syndrome and for its resolution were compared by using the log rank test. The estimated cumulative incidence or resolution at 3 years and the risk reduction, heterogeneity among strata, and interactions between treatment assignments and covariates were assessed by using proportional hazard regression. Fixed effects models with the assumption of normally distributed errors were used to assess differences over time in body weight and plasma glucose and glycosylated hemoglobin values among the 3 groups. This table shows the prevalence of the metabolic syndrome and each of its components in the 3,234 participants examined at baseline. 53% of the participants fulfilled the criteria for the metabolic syndrome. This proportion was relatively constant by age group, as you can see here. However, significant differences by age group emerged for the separate components of the syndrome, as you can see here. Prevalence of low HDL cholesterol level ranged from 70% in those 25 to 45 years of age to only 40% in those aged 60 years or older. High fasting plasma glucose level, high blood pressure were more prevalent in older participants. Prevalence of the components also varied by sex. Women were more frequently had increased waist circumference and low HDL cholesterol levels, while men had more frequently high triglyceride levels, high fasting blood glucose levels, and hypertension. This table shows the correlations among the different components of the metabolic syndrome at baseline after adjustment for age, sex, and ethnicity. Also shown are the correlations with the homeostasis model assessment score for insulin resistance. The model assessment is a method used to quantify insulin resistance and beta cell function. Apart from the anticipated high correlation between systolic and diastolic blood pressure and HDL cholesterol level, other major correlations were those between homeostasis model assessment score for insulin resistance and waist circumference here, uh, and HDL cholesterol level and fasting plasma glucose level. This table suggests that lifestyle reduces the incidence of all components except HDL cholesterol level, while metformin is effective only in reducing the waist circumference and fasting glucose level. This table also shows the effect of interventions on each component among participants who met the specific component criterion at baseline. Both interventions decreased the prevalence of low levels of HDL cholesterol, increased waist circumference, and plasma glucose level, fasting glucose level, while intensive lifestyle intervention also lowered the prevalence of increased blood pressure and triglyceride levels. This figure separately shows the cumulative incidence of the metabolic syndrome by time since randomization for the 3 intervention groups after exclusion of baseline cases. The incidence is highest in the placebo group. By 3 years, 53% of the participants in the placebo group had acquired the metabolic syndrome compared with 47% in the metformin group and 38% in the lifestyle group. The cumulative incidence overall was 61% for the placebo group, 50% for the metformin group, and 38% for the lifestyle group. In a proportional hazard analysis, lifestyle intervention yielded a reduction of 41% in incidence of the metabolic syndrome compared with placebo and a significant 29% reduction compared with metformin, which itself yielded a 17% lower incidence than placebo. This shows the cumulative incidence of resolution of the metabolic syndrome by treatment group. Although the pattern is somewhat similar to that seen for incidence of the metabolic syndrome, with the best result at 3 years occurring in the lifestyle group and an intermediary effect noted for metformin, the differences are less striking, of course. By the log rank test, only lifestyle showed a significant effect compared with placebo. Nevertheless, prevalence at 3 years did vary significantly by treatment group. 18% of the placebo group, 23% of the metformin group, and 38% of the lifestyle group no longer had the syndrome. The strengths of this trial are this data provided potentially important clinical information concerning the metabolic syndrome and its prevention. This data provided further evidence of the potential benefit of the diabetes prevention program interventions beyond diabetes prevention alone and raised the additional possibility of cardiovascular prevention. This data provided an extensive and detailed description of the metabolic syndrome in a high-risk population and revealed important differences in composition. The limitations are the study involved a volunteer group with impaired glucose tolerance, which limits generalizability. These intervention results apply primarily to persons with impaired glucose tolerance and cannot be immediately translated to other groups. So from this study, we learned that the metabolic syndrome affected approximately half of the participants in the diabetes prevention program at baseline. Both lifestyle intervention and metformin therapy reduced the development of the syndrome in the remaining participants. Future follow-up of the cohort is required to determine whether this particular combination of risk factors or some other variation better predicts cardiovascular outcomes. The intermediary effect of metformin, which closely mirrors the pattern of results for the overall trial in terms of diabetes prevention or delay, further underscores the preferential value of lifestyle as the initial approach to prevention of the metabolic syndrome and its cardiovascular complications. Thank you so much for listening to me. If you have any questions regarding this topic, please email me at shravani.motamari@gmail.com. Thank you so much.